Right, good afternoon, everyone. We're going to kick things off today. We've got a few people here in the audience, and we've got quite a few people online as well. And I'm sure people will come and go over the course of the afternoon. So I'm Chris McKenna, I'm the Medical Director, and it's my pleasure to be here and to open today's Celebrating Success in Fife afternoon, which we are, as previously, running in partnership with the Royal College of Physicians of Edinburgh, and Dr. Baker is here too. Are you going to come just straight after me? Prizes at the end. Okay, we'll let Kerry speak later on. But this isn't really about us, it's really about our trainees, our resident doctors, and all the amazing contributions that you've made in terms of the projects you've been undertaking. And I'm fully aware that this takes a huge amount of extra effort because I know how busy life is here working in Fife. I realise that this is all extracurricular, and thank you for all the efforts that you've put in. And I've seen the posters outside as well, some amazing audit, quality improvement and research work that you've been undertaking. And NHS Fife is a quietly optimistic and determined and ambitious health board. And we're moving ever so slowly but surely in the direction of becoming a teaching health board, and that will materialise this year, which I think is really exciting, but it really talks to that commitment that we have to education, research and innovation, and we see all of that on your posters here today. And of course, we're also not too far away from the beginnings of Scotcom Medical School in January 2026, and huge amounts of efforts from our clinical teams, our medical education teams, and our partners at St Andrews University, who will be delivering on this amazing project for us. And it is this project that leads us into very special territory as being one of 5 teaching health boards in Scotland, and not in the same category as others anymore, which will allow us to really progress and allow us to develop as that kind of teaching centre of excellence. I'm not going to be able to stay for all today, unfortunately. I'm always pulled in many directions in this job, but it'll be my pleasure to stay for a short while. So I'm going to hand over to our first speaker, who's going to be online, I think, except I don't have the thing in front of me, so I've forgotten who it is. But Oliver is going to be keeping tabs on us all today, are you?
I can try.
Okay, so I'm going to hand over to Oliver, who's going to walk us through any housekeeping stuff.
Fantastic, yeah.
Great.
No, all good.
Thanks, Oliver. Thanks, everybody.
Thank you. Yeah, good afternoon, everyone. I'm Oliver, one of the Chief Registrars, and I'm here representing the Chief Registrar Group, who are absolutely thrilled to be celebrating success this afternoon. And our first speaker is Rachel Pusty, who I think I've seen online, should be there and is unmuted. Now, Rachel, your slides should be up. How do we give Rachel the ability to move her slides on?
So we'll just take ours away for now.
Yeah.
And then Rachel, if you're okay just to click share.
Yep.
On Teams.
Sorry, it's
Hi Rachel, can you hear us okay?
Yep, I can hear you. Yep, can you hear me?
That looks like you've got it. You just need to put your slides up.
Is that working?
Right. Okay.
Cool. Good to go?
So we've got but now we need to move this over here.
Yeah. Right. Rachel, can you give us a bit of chat for a...
Yeah. Is it working? Microphone's working?
We can't at the moment.
Okay.
What's happening there? We still can't hear you at the moment.
My microphone's switched on.
The online speaker. Yeah, it's on quick share. Not sure how else we turn that up.
We can hear you.
Oh, they can hear her online. It's a problem in the room. So Sean Macaulay's just put in to say that they can hear you online, Rachel, but we can't hear you here in the room. So it's something we're doing wrong.
Try it now.
Can you hear me now?
There we go. Fantastic.
Yeah,
Brilliant.
cool. Right, slides. Okie dokie. So my name's Rachel. I'm one of the anaesthetic trainees that's just rotated through Fife. Sorry I can't be there today. I'm at a course in Edinburgh, so I'm having to tune in from line, so sorry about that. I'm here to talk to you about a project that we did in the Department of Anaesthetics on the spinal packs, utilisation and wastage. So firstly, spinal anaesthetic is a type of anaesthetic. It's a regional anaesthetic that's used by many surgical subspecialties, including kind of orthopedics, gynecology, obstetrics, general surgery, all of which we do in NHS Fife. This is what we use in NHS Fife, so it's a Pajunk basic spinal pack. So for every spinal anaesthesia, we open one of these packs up and use the equipment in this. Recently, we've transitioned from using chlorhexidine kind of a wash to a chlorhexidine spray when we're sterilising the back. And anecdotally, we noticed that since that change, we've introduced quite a lot of wastage from these basic packs. So we kind of created a project to aim to assess the extent and the implication of that equipment wastage with these basic spinal packs and propose kind of strategies to reduce that waste. So why bother doing this project? So NHS Scotland is aiming to become a net zero health service by 2040 at the latest. And NHS Fife has actually published online that they recognise their duty to act and address the climate change issues and kind of work with NHS Scotland to become a net zero health service. Now, naturally, this is a balance between having the relevant equipment needed to perform the procedure, but then also kind of the wastage and the cost associated with that too. And I think we just need to be careful not to swing too far the other way, but equally, it's important that we reduce waste as much as possible so we can reduce our CO2 emissions and help NHS Scotland get these sustainability goals. So what did we do? Initially, we published a survey. So that survey went out to all the anaesthetists in NHS Fife. We just had the survey out for 48 hours and we had 27 respondents, which is pretty good. This graphic basically shows all the equipment listed down here in the pack and what equipment people felt they used regularly and what equipment they didn't. So immediately you can see that actually some of the gauze in the pack was being binned every single time. The plastic containers were being binned, plastic forceps were being binned, whereas some of the things were kind of an essential to the kit. So the drape that we use to keep the sterile field, our drop needles and some other needles as well. So we kind of took this data, we thought actually this is a useful kind of trend, but I think we needed some physical data to collect and actually see if that reflected actual practice. So then over a 2-month period, we collected data on different anaesthetists in different subspecialties doing a spinal anaesthetic to see what equipment they wasted and what equipment they were used. So this graph, so just to explain this, so over that 2-month period, we collected data on 40 spinal anaesthetics. This again is all the equipment in the pack along the bottom. In the green is what we used, and in the red is what was wasted. So again, if we just kind of break this down a bit further, there's 3 types of gauze in the packs. So there's small gauze, large gauze, and gauze squares. Basically, the kind of take-home message is we probably only need 1 type of gauze in the pack now. As you can see, we binned almost every single time the large gauze balls, and then there was a bit of a split between the squares and the small gauze balls. But I think we just need 1 type of gauze. The 60ml plastic container, which is that wee galley pot, was binned almost every single time, and the plastic forceps were binned every single time and not used. And that's just since that changed the chlorhexidine spray. We no longer need that equipment in this basic pack, where some of the things were more essential. So again, the drape, the drop needle, the kind of 10ml Lure slip syringe for local anaesthetic to the skin. They were much more essential and we probably should keep them in a pack. Another thing that was maybe a little bit less obvious, so there's 2 different types of syringe called an NR fit syringe. This is the type of syringe that we use to inject local anaesthetic. The reason it's NR fit is to avoid kind of putting local anaesthetic in the wrong place. So it's a type that only fits on an NR fit needle. Most people use a 3ml syringe. A couple people were using a 5ml syringe still, but actually very few, 75% of people were still binning the 5ml. So maybe that's something we could take out of the generic pack, but then put in if a special circumstance needed. So just to give you a visual of that pack again, so this is the pack laid out, and actually from that graph, we could eliminate kind of half the products in it. There's obviously the environmental burden of excess waste. There's also an economical burden. The economical burden of destroying the waste as well. The clinical waste, like the cost of destroying an orange bag, is significant. And that's why theatres, there's a lot of recycling going on in theatres, but definitely some of this still ends up in the orange waste. And then the other thing to say is this whole spinal pack here costs £5.78 per unit. We do about 3,200 spinals a year in NHS Fife. So actually, when you equate that, that's £18,500 spent on just these basic spinal packs, and we're binning half the equipment in them. So kind of what's next? So obviously, theatres are doing really good things to kind of improve sustainability, and we're making good steps. Our next step for this project is to speak with the company Pajunk and kind of liaise with them about kind of if there's alternative packs, if they're the kind of cost of a more specialist pack as well, because it might be that that is more expensive, but it's kind of weighing up the cost of the wastage versus the cost of a different pack. And also I'm quite kind of positive because Pajunk on their website, they advertise that they kind of share environmental awareness and they actually take some responsibility for sustainability. So I think if we kind of raise these issues with them, then hopefully they'll come back to us with a positive outcome. Once we've kind of changed our equipment, their plan is to then re-audit and see how much wastage we've changed and if actually we've kind of swung the balance too far the other way or if it's a positive move. If it is positive, I think that's a very simple methodology. We can definitely roll it out into other procedural kits. So just an epidural kit here and then a CVC kit, so central line kit. Again, we'll do these very regularly. You know, there's a lot of wastage from these things. And I think it's something that could be rolled out into other projects to help kind of environmental waste get reduced. Any questions?
Put your hand up online. Go for it. So, Dr. Lee.
Hey, well done. Good presentation, Rachel. Just wondering if you ever looked at putting the kit individually in theatre and see how much that would save.
So do you mean putting in completely getting rid of the packs and then just having individual kit?
Yeah.
Yeah, no, it's not something we considered. I suppose the benefits of having a pack is that it creates you that sterile field rather than you'd have to probably open a clean dressings pack every single time on top of one of the trolleys. So it then might create additional waste, but it's not something we actually did look at.
Yeah, but we're recycling the packaging, so yeah. That might help. Just a thought. Well
yeah, absolutely.
Thank you, Rachel. Interesting. Do you think that we're going a full circle now, and there might be the next step will be to go back to reusable syringes and needles?
Could you hear that online?
Can you repeat it just?
Yeah, so the question was, do you think there's going to be a swing back towards reusable needles and syringes?
Yeah, no, I don't think so, because this procedure is done. You have to scrub and be completely sterile. Otherwise, you're introducing potential high risk of infection into someone's neuraxial system. It's not worth the risk.
You're saying some of the more senior people in the room commenting that they were used in the past.
Yeah.
So it's permanent equipment. You just sterilize.
Yeah.
Like that.
Just talking about the potential for re-sterilising of permanent equipment in the future. Yeah, Dr. Thompson.
Yes. So how are you going to get the message out that you're removing some pieces of equipment and control the annoyance from people like me when you're taking a 5 ml syringe out of the car?
Did you hear that one? So the question was how you're going to manage the egos of the people who really like 5 ml syringes and make them use 3 ml syringes instead.
I think we'll have to do some number crunching and come up with hard facts to prove the cost benefits, and that might change the big bosses' minds.
Fantastic. Well, thank you very much, Rachel. That was great. So,
No, so thank you. Sorry, I can't stay for longer.
that was great. So fantastic. If I can ask you to stop sharing your screen, and then, Chris. Next we're going to move on. Dr. Cook, are you there online?
Yeah, can you hear me?
Fantastic. Yeah. So again, if you can click share on your screen and share your slides yourself if you're able to.
See if this works. Let me know if this is working.
Yep, it's working for us here in the room. Can people see that at home? I think so. Yeah, perfect. Great. Right, over to you.
Thank you very much. If I'm moving the slides across, you're just seeing the first slide, is that right?
Yeah, yes.
Yeah, okay, grand. Thanks everyone. I'm Kiva. I was one of the psych trainees in Fife. I'm now in the Borders, but we did a wee bit of work in the last rotation looking at the psychiatry handover process. For anyone who's not worked in Fife psychiatry, out of hours, we have a bit of a problem in terms of sites. So we cover Kirkcaldy, Whitemansbury, we cover Stratheeden, Queen Margaret and Dunfermline. So we're all over. There's about 46 miles of providing out of hours service from 9 p.m. or from 5 p.m. to 9 a.m. and then weekends. So what we currently had was an email inbox service. So all Fife trainees, consultants, regs, important people to the psychiatry team also. So the unscheduled care team and a lot of the senior nurses as well have access to the email inbox and would do their out of hours handover straight to that inbox. And it's the sort of unscheduled care team and the long day doctor's duty to report to the inbox at the end of the day and see what's happening and start to prioritise their jobs. So that process in itself, we're getting lots of emails from different places about different things. When you're the long day doctor and you've just pulled up to Whitemansbury at 5 o'clock, you can get, you know, a lot of emails, sometimes not as much as you would hope, with a name, a KI number, what ward they're on, maybe. Sometimes you're not even sure where they are, with detail, for example, chase someone's bloods. And that's absolutely fine up until the point where you maybe do a bit more digging or you hadn't realised in your list of prioritisation that actually the bloods are quite important because you're waiting on a repeat of, for example, a high potassium or just something that actually you maybe didn't prioritise and you end up feeling a wee bit confused or a wee bit like that wasn't the most safe option. So we had a look at the process, and last year one of my colleagues, Conor McIntyre, had done a bit of a review of this as well and tried a period of a Teams handover call for all the sites. Now, that unfortunately wasn't sustained at the time. It managed about a few months. People sort of dropped off. It wasn't used very well and continued to use the email inbox. So we looked at that review right up and sort of used it to formulate a form survey we put together just for all the trainees in psychiatry, including the F2s, GP trainees and regs, just to try and fill information for who we thought who would actually be on call, felt that they needed to get the information to have a safe handover process. So not reinventing the wheel by any means, just gathering the information that we felt we would need and going from there. Some of that information we've just added here. These are just screenshots from the form survey themselves. But I suppose overall, the main results sort of said 60% of the trainees felt either neutral or just didn't agree that the current handover method that we had was safe with and effective for the transfer of information for patients. So not good enough. 90% of them felt that the email inbox was appropriate, but 50% of them felt that there should also be a formalised Teams meeting if we could develop it. And 70% of them felt that it'd be helpful to develop a template for the email handover as well. So yes, having the email handover important, but actually having a standardised S-bar of what we were putting information-wise in that, so that there would be a good enough level of detail that people felt that they could safely prioritise the jobs as well. From that, we also gathered information about who should be on the call and what would the most appropriate time for the call be. So we ended up developing it. So we had a new weekly call every day, weekday, 4:45 to 5:15, and it was led by the duty doctor, so the long day doctor who was on call. It was their responsibility to start the call at 4:45. It rotates, so every day would be a different person. It's your responsibility, and we had a pro forma document built up with all the information sent out to all the trainees and consultants and lots of people. And we used the psychiatry division team meetings as well to sort of roll out that information to the senior docs as well. And we have been using it since February. We also tried to roll it out around changeover time in February to make sure that during the induction process it was explained how this was going to be working. And that's what we've done. In terms of looking at it since, we have done a bit more of a survey in April, looking at how the current trainees have felt that that process is going. And there's very mixed feedback. Unfortunately, we're still looking at pretty much a 50-50 on how people feel about it. Some people are managing to get to the meeting at 4:45. Some people are very busy and haven't been able to and are still using the email system. It is a prerequisite that we are expecting everyone to send an email as well anyway, so that there's a paper trail, but then that leads people to be less likely to use the Teams call because they're already conducting an email at the end of a busy day and trying to get home. So it's not been perfect, and it's not the best system so far. We're still looking at it, we're still reviewing it. But I suppose in terms of the trainees here today, like, the take home is just always feel like you can look at handover. It is something that's really important. We know that it can be reviewed, and if you actually don't feel that it's safe and it isn't useful for the purposes of what we actually need it for, you can do something about it. And it is a good bit of work to try and roll out, but things can change, especially things as standardized as handover. So that's it basically. Yeah, any questions? Probably won't be, but that's me. Thank you.
So thank you very much. Are there any questions in the room or at home?
I think you could run back again just to the Teams handover without it. So I know you said you felt an extra paper trail, but it's well established in multiple areas of NHS Fife where we just have verbal handovers, including for a lot of what we do in medicine. So you wouldn't be unique in not having a written handover. So would that be maybe another cycle of a quick you would try?
I don't know if you heard the question there at home. The microphones don't always pick up, but the question from Dr. Baker there was whether you consider trying another cycle, dropping the email handover completely and just having a verbal handover in line with other areas in NHS Fife.
Yeah, absolutely. It has been mentioned. We haven't actually planned to try it as yet, because I think there's a significant fear that if we don't have the email, we may not get any handover from some people. I suppose it is a worry, especially around the sort of, so if the call itself continues 4:45 to 5:15, the worry is that some people may leave slightly earlier, or more than likely be leaving later than that, or finishing up, especially when you think about the wider team being involved. So for example, a consultant from one of the community teams has been out to see a patient, detained them throughout the day, is trying to get them admitted to one of the wards. It may be 6-7 o'clock before they're getting their paperwork done and trying to pass on to the duty doctor that that's someone who's coming in and they need to be, you know, formally admitted with an admission document and bloods and ECG and things like that. Or maybe they want a certain medication written up for them. So yeah, I suppose the worry is if we don't have the email system, that information may not have got directly to them, especially if they don't have the contact information. So it could be tried, and it has definitely been mentioned, but yeah, I think it would be up to the current team who are taking it forward and looking at it again, whether or not they tried that.
And James.
If you look at, sorry, I haven't seen enough on the slides. If you look at how much of the barrier was how busy people were at the end of the day and their perceived busyness at that time versus the process of the handover itself? Because it seems from what you're saying, like some of it is that people don't feel they have time at the end of the day to attend the handover.
So the question from Dr. Woods there was whether you felt there was, whether you looked at whether it was perceived busyness at the end of the day that contributed to this as much as the process.
Yeah, we did. So they're part of the forms feedback for the second sort of collection did have a sort of other free text box for basically if you weren't attending, why did you feel that was happening? I think the main feedback was that people didn't have within the half hour period weren't getting to be able to join the call. Other people, actually, some of the feedback was that they were just forgetting about it and they were so used to the email process that they were just continuing to do that and knew that that would be accepted and didn't do any more than that. So we do have a bit of information on that, and the main barrier actually being time. And I suppose the way to deal with that is to open up the time frame. But again, slight difficulty in terms of bases. So the out of hours base is the unscheduled care team in Whiteman's-Bray. So usually we give trainees time between 4 p.m. and 5 p.m. if they're on the long day to get from their base, which could be any of the other sites, to Whiteman's-Bray, and then start the call. Whether or not we open that up to you start the call wherever your base is and then move. Again, there are ways around that. It's just adjusting.
Fine, we've got one final quick question.
So I've noticed that on WhatsApp, particularly those younger than me are sending me voice recordings and little video clips to communicate, which is good. Do we think we could do that handover then? Presumably part of the difficulty James is going over is it's actually a time problem rather than a medium problem.
Yeah. So the question there was from Dr. Thompson to say whether we could utilise technologies like voice notes or video clips on WhatsApp or similar as a form of handover to avoid it, to do asynchronous verbal communication.
I fear confidentiality rules may come into play fearfully if we did introduce something like that.
On Teams or Panda or one of the safe
I think actually what could be really helpful, and we may think about this and try to incorporate it, is actually just having an open telephone line and even having the verbal, you know, so if we're just beside a phone, hit into the inbox, the Teams call is open, but if anyone finds it easier just to pick up the nearest phone and dial the internal call and give me a verbal handover, sometimes even something like that could be more helpful than having to get Teams open, join the call, wait for your turn in the call, you know, things like that. So definitely there are alternatives that we still can try. Not sure about voice notes, but definitely a phone call with a verbal handover, definitely.
Fantastic. Right, so we need to move on to keep ourselves on track for this afternoon, but thank you very much for that one. And what I will try and do now is, if I can ask, how do we, which one do I want? What am I doing wrong here? That's the one I want. Right, so next, Dr. Chandler. So we are now, is Prezi open?
Okay, so is this the...
This is the Prezi one?
Yes.
Is that Nash? Yes, that is showing.
Yes.
This should work. There is, it may not work.
I will try. This might take a couple of seconds to load, so I'm going to pre-warn you at the end of this talk, I will require a little bit of audience participation, so just psychologically prepare yourselves. So I am giving a talk about an audit I did at the Royal and also here on hypoboxes, and this was after 2 experiences I've had on a night shift on a ward I've never set foot on in my life. Hypoglycemia, nobody can find me anything to feed these patients to try and fix a medical emergency. And in 2025, I feel like this shouldn't be happening. Even Paddington can manage a hypo, given that he always has some instant release glucose and some complex carbohydrates in the form of a marmalade sandwich. So will this work? Yes, it will. Amazing. So hypoglycemia is more common overnight, and obviously overnight we're covering lots of wards where we maybe have never been before. It's easy to manage if the resources are available, but if we don't have the resources, it can have a significant morbidity and mortality. And in both of my unfortunate episodes, our patients at one point or another started losing their airways because of the hyperphosphatemia. So these are serious incidents that never needed to go that far. So, audit. We were looking at specifically the availability of resources and people's ability to access these resources. So we were asking the question, is there a hyperbox on every ward? Are they in good condition? Are they broken? Are they easy to find? Or are they hidden away in a cupboard? Do the nurses know where they are? And are they happy using them? Do the doctors know where they are? And are they happy using them? In the RIE, mixed results. So the wheat balloon bit is all of the wards that had hyperboxes in good condition and somewhere obvious where you could easily grab it and see it. And as you can see, that's about a quarter of wards. So 3/4 of wards either didn't have a box, their box was broken, their box didn't have anything in it, or it was hidden in such a labyrinthine package that actually it was no use. So not great. And just to go back, sorry, 96% of nurses knew where they were, but only 17% of doctors actually knew where they were. So, Kirkcaldy. Better. Over half of the wards had a box in good condition that was easily visible. And the purple are wards where they had a box in good condition, but I would say moderately visible, as in if you kind of knew where-ish to look, you'd find it, but it wasn't maybe super obvious. So over 3/4, I think, were okay in that regard. 100% of nurses knew where the box was, 16% of doctors. So
I'm so sorry to interrupt you mid-presentation, but people online can't see the presentation. Yes, so let's just get Teams back open.
Technical difficulties.
Yes, apologies for that. It's shooting. It's on the screen. Just share again.
Sorry, it had to be difficult.
No, not at all. It's the tag being strange.
Yes, amazing.
Okay.
Grand. Okay, sorry, I can go back and show you online the slides with the graphs. So what did we do about it? Oh no, it's not working. That's all right, I will use a mouse. What did we do about it? So obviously we found different information in the RIE to Kirkcaldy, so we had to do different things. In the Royal, there was no point in kind of focusing on people's knowledge of where the boxes were, because over half the wards didn't have a box in a useful place. So we talked to various different teams about replacing the boxes and standardizing the locations. And unfortunately, even with my best hard stare, we were not able to really facilitate any meaningful change at the time, although there are teams in the Royal that are still working on this. So we didn't re-audit the Royal because there was nothing that we'd really changed. However, in Kirkcaldy, because over half of the wards had acceptable boxes, we realised the problem was more with regards to people's knowledge of where the boxes are, and particularly doctors' knowledge was really lacking. As I say, when you're on an unfamiliar ward in the middle of the night, the last thing you want to be doing is hunting for a box. So we put up posters in all of the wards. You might have seen them. They're very orange, so hopefully very obvious. And on the posters is just written where your box is. And because we noticed the glucagon is often in the fridge, not in the box, we also said where the glucagon on that ward is, mostly the fridge. Some wards didn't have glucagon, so it would say your nearest glucagon is in this ward in the fridge. And statistic, we made a significant difference. So we re-audited the doctors and the nurses, and we saw that actually with these posters, more doctors were aware of where to find the boxes than they were prior to the posters. The nurses already had very good levels of knowing where the boxes were, so that didn't really change. So that's really positive. There was a significant increase in the awareness, as I said, but also we did a little bit of mixed methodology, and we also asked people, mainly resident doctors, what would also make this process better, what would make them more confident in managing hypos. And what came up a few times was that actually quite a few, especially FY1s and FY2s, aren't super confident with when to use glucagon. And so that's something we'd maybe like to focus on. So what's next? Ideally, as I say, we are working on trying to improve just the resource availability in the Royal. If we're able to do that, we can re-audit the whole process. We'd really like to carry out some teaching with regards to glucagon specifically and when to use it. We'd like to include information just such as the posters in inductions so that new doctors coming into the hospital know, if not where to find the hyperbox in every ward, where to find the information of where to find the hyperbox. And to take this even further and look at the effect this is having on patient care, we'd like to look at all of the datixes. In theory, every hypo is datixed. And so we'd like to see if there's anything else we're missing in the process of treating these hypos.
A letter regarding Hugh Bernard, 1402390378, letter to the patient with a copy to his GP.
I think, oh, there we go. That was not the crisis I planned, but there is a crisis. Paddington is having a hypo. Can anybody find a hypo box? There is one in this room, I promise you. Somebody find a hypo box. It's orange, it's in the room. Yeah. Does anybody want to help Paddington? Is anybody going to help Paddington? There we go. So hopefully the panic you just felt. But luckily Paddington had a sandwich, so he managed to fix it himself. So thank you so much. Are there any questions? Yeah.
More of a comment.
Okay.
Thank you very much. Interesting. We knew we were better than the Royal, but
yeah.
Please could I ask you to speak to Kath Patterson?
All right.
Because there is a diabetic component to the shadowing week.
Oh, right.
And I'm pretty confident that they do hypos in that. But could you speak to Kath to make sure that they're addressing the glucagon specifically, that you've identified that people feel less confident about? And maybe you could also share this with her, because maybe she could share what your posters look like.
Yeah, absolutely. Yeah.
Yeah, I just wonder whether it's worth considering if there's a guide that could be put into the hypo box.
There is.
So it's like where to use glucagon.
There is. Yeah. So every. Yeah.
Just repeat the question.
Oh, I'm so sorry. One was a comment that the Royal is better. No, Kirkcaldy's better. Kirkcaldy's better. Prof was just talking about adding into the education that's already been done on diabetes, more specifically about glucagon, and then there was a question about including information about glucagon in the boxes. Actually, this is another thing where Kirkcaldy is better. In the boxes, on the lid of the boxes, there is the hypo algorithm, which includes when to use glucagon. But obviously, because it's in the boxes, if you can't find the box, you can't find the algorithm. And I think one thing that does confuse everything a little bit is that all of the glucagon is kept in fridges, which according to my supervisor, who's a toxicologist, is not necessary. But it seems to be such the habit that I thought actually maybe trying to tackle that might be challenging. But yes, so that is included, but would be a point for the Royal as well.
Especially the Royal have more room for improvement. How might you convince them of that?
So I think the main thing we came across, so to be honest, I was doing this research in the first block of the year, and then I moved to Kirkcaldy and I've struggled to kind of keep pushing it forward at the Royal, not physically being there. The main barrier we had to that is money. Just we couldn't find any one specific person who would necessarily say, right, we're going to replace all the hyper boxes. I think another issue, if I can show you I wasn't sure if I'd be able to make a presentation, so I did. These are the hyper boxes in the Royal. They're orange. I think they're standardized, and you can only, because of the foam inside, you can only put the stuff that comes in them. So you can't put other stuff in them, and I think that's why a lot of them break. And then when they're broken, the lids just fall off, and then all the stuff falls out. So there's quite a lot of broken, empty orange boxes. Five, again, much better. Have these boxes, which I think are just, I don't know, from IKEA or something, but they're all standardized and they're just a box. So you can fit your 10% dextrose in there, you can fit all of your glucotabs and glucogels in there. So I wonder if in the Royal it might be cheaper not to go with kind of branded ones, but also just better, because then you can standardize them and replace the individual components more often. Because I'm imagining whoever's selling these wants you to buy a new box every time as opposed to just replace the components. And so trying to convince somebody of that would be our next step in the Royal.
Let me know if you need to spend any or anything else over there.
Amazing. There is Dr. Tyndall, one of the Regis, they're on it in the Royal. Yeah.
Thank you.
Thank you very much.
Thank you. Right. I'm now going to try and go back out of Prezi into the other presentation. See if I can make this work. So, what's happened there? Righto. So, next. Dr. Gosby, are you here or are you online? Oh, and
I'm online. Hi,
fantastic.
can you hear me okay?
Absolutely. Then in that case, I will unshare. And if you want to share your slides
That's no problem.
yourself. Yep. Do you have your slides there to hand to share?
I should do, yeah, I just need to get them up.
Yeah,
might take me a minute, sorry.
So if you want to share those.
I don't think that's come up. Let me try again. It's not coming up, is it?
Right. In that case, what I will do is I will share them from here. And when you want to move slides, you just say, move on. Or
Okay,
next slide, please, in the style of Chris Winty.
Yeah.
Yeah, we will pretend we're at a pandemic briefing. Right. There we go. So you should be able to see those at home.
I can see them.
Just tell me when you want to move on.
Lovely, thank you. Hello everyone. So firstly, a big thank you to the Chief Registrar for organising this conference. It's been really fascinating to hear the array of work that's going on in Fife. My name's Jenny. I am one of the FY2s currently doing an academic or specialised foundation programme here in Fife. Mine's in medical education. So today I am going to talk a bit about some of my results from my systematic review I'm undertaking, looking at community-based medical education, trying to create a unified definition. Firstly, I'd just also like to say a big special thanks to Noni Mordy and Richard Stephen for their support and contributions. Next slide, please. So first, I'd just like to give a bit of background, a bit of context to community-based education. It's really a concept which started to appear in the literature kind of late 70s, early 80s. And there was a WHO study group that met in 1985 to really discuss the significance of community-based education for health personnel in kind of their endeavour for achieving health for all and good medical education. And they essentially note within their report that came out in 1987 that there is no standard definition for community-based education, but they do give kind of an example definition, which I've taken a bit of an extract from below. That essentially says that community-based education is a means of achieving educational relevance to community needs and consequently implementing a community-orientated educational programme, and essentially focuses on learning activities that take place within the community. So why do I think that greater clarity is needed? I think this is quite a non-specific definition. I think there's quite a lot of inconsistency within the terminology, and this is an anecdotal acknowledgement as well when I was doing my reading around the area, but it's also noted from other researchers within the literature. So there's many papers that don't cite a definition for this concept, and there's many that use many different concepts. So I think it's really important that we have a standard definition, because otherwise that allows room for misunderstanding, and it's a bit of a detriment to the evidence base, and it doesn't allow programs to really be validated or compared and contrasted if we're talking about different things. And it's important that we evaluate programs and make sure that they're evidence-based. So we need to guide educators, and a standard definition is a really helpful way to do that. So why community-based education at all? Well, it's part of a lot of organisations and different bodies kind of look for the future of healthcare. There's a desire to improve community healthcare, and part of the NHS long-term workforce plan is really to focus on improving community healthcare and using it as a educational development as well. And the GMC also recommend that their graduates in outcomes for graduates that they can adapt to working in the community and be generalist in nature and work in the community as well. And the WHO also recommends that community education is important for achieving their endeavour for health for all. There's also some benefits that have been potential benefits which are noted in the literature, including increased kind of student satisfaction and enjoyment from learning experiences, as well as improving their communication skills and increased continuity as well. I think it would be hard not to note that there's also quite a rapid increase in medical students as part of trying to relieve the pressures and trying to future-proof the NHS. The projected numbers of medical students are projected to increase and double by 2031. So community-based education has also been proposed as a way of helping to facilitate that as well. Next slide, please. Sorry, I tried to move it and I can't. I'm taking a systematic review of the literature, and that's 858 papers. But today I'm just going to talk a bit about the UK papers that I've looked at earlier this year. So I've done a literature search and I followed the Prisma guidelines, and this is what I've kind of come up with for the UK papers. So there was clear inclusion and exclusion criteria. There were 68 papers that came up when I screened it for UK papers. And as you can see in this diagram here, it's just a bit of a pathway. So essentially 19 papers passed screening, 4 papers had a community-based education definition, which was clear within the literature, and then 12 papers described some sort of community-based education programme. And those were the 2 outcomes that I was looking for, but today I'm just going to talk about the definition because just in interest of time. Next slide, please, sorry. So the results essentially are listed here. So these are the papers that had clear definitions within their work, and I've taken some of the key features of each definition there and underlined them. So community-based education is not within hospitals. It's something that is learning activities which occur in the community and community settings. And there is an emphasis in the literature on social accountability, multidisciplinary team working, and recruitment into primary care as well. The actual teaching methods weren't that specific, and this definition at the bottom said any variety of teaching methods can be used, but it should promote an understanding of health concerns at the community level. Next slide, please. So this is the working definition that we came up with after looking at the UK papers. I'll read it out briefly here, but please feel free to read along. So community-based education is teaching or learning activities which are rooted within the community, both in terms of location of education delivery and curriculum content. The CBME programmes reflect the health needs of individuals within the community in which they are located and utilises community health services. There should be an emphasis within the curriculum on social accountability and multidisciplinary team working. Next slide, please. So in terms of next steps, I'm working my way through the 858 papers. So I'm getting an international perspective there. I want to broaden out that definition and try and create a basic framework for community-based education as well. And I will do that by doing a bit of a thematic analysis of the results and get through those 858 papers. That is the end of the presentation there. So thank you very much, and I'll happily take any questions. And thank you, Oliver.
Are there any questions in the room or online? Dr. Modi.
Two questions. First one is, through your work, you and I work together and know why this is important and why we've chosen this topic. But I wondered if you could express to the people online and in the room as to why this topic is of interest to us here in Fife.
Did you hear the question there? So Dr. Morley was asking if you could explain. Oh yeah, so Dr. Morley was asking if you could explain why this is of particular relevance to us here in Fife.
Yeah, I think, yeah, exactly. So I didn't mention this today. Thank you, Dr. Mordy. So ScotCom is a new project, a new programme in St Andrews. I don't know if everyone's heard of it, but essentially St Andrews for the first time are going to graduate their own medical students instead of all students within St Andrews going off to different teaching hospitals and different teaching universities for their clinical years. A cohort of the medical students are going to stay and be undertaking community-based education, which will be predominantly in Fife. So they'll be based out of Cameron Hospital for their clinical years. So that's why it's of particular interest to Fife and why we were looking at it.
Dr. Woods was first, fastest finger first.
So follow-up questions is, how does ScotCom currently define community-based medical education?
So the question from Dr. Woods was how ScotCom currently defines community-based medical education.
So that's a great question, and I actually don't know the answer to that, but I can find out.
Professor Woods says they don't.
There we go
Fenny.
then.
Dr. Fenny's question is how the authors in those 4 papers came to those definitions.
That's a great question. Some of them just kind of describe it that way. So a lot of the definitions that I've been seeing within the literature are constructed by themselves. It's people taking their own initiative and of how to describe it, which is why I wanted to kind of get a good grasp of that within this project, because I think it's important to have an international perspective on how we're describing this and what this actually means in practice. Some of the other definitions, if they do cite other authors, it kind of varies. There's no particular one. I have seen that the WHO definition being cited, but not very commonly.
And I'm going to ask a question of my own, if that's all right. When you said that this education needs to be rooted in the community, what sort of patterns have they seen of delivery of that? Is it by clinicians who are working? Are we talking about primary care physicians? Are we talking about hospital clinicians who work in community settings? Is it non-clinicians who would then be supervising and delivering this content? Or can it be delivered from hospital-based specialists for trainees?
I think that's a really good question. And that's the second kind of part to the project I'm doing at the moment, is looking at what even is a community-based education programme and how do we define that. So there is multiple different specialties which have community bases as well. So things like palliative care, paediatrics, psychiatry. These are all specialties that have a community-based element as well. Of course, there's going to be a large proportion of it will be general practice, and I think that's more of an ease and more of a practicality than anything. But there's also quite a large focus in the literature of community hospitals and doing longitudinal clerkships in community hospitals rather than in either district generals or tertiary centres.
Fantastic. Right. Final question.
Are there any metrics or tests that were done to compare how effective it is against current practices in terms of education?
So the question was whether the 4 papers you identified had any metrics of which is more effective or how effective it is compared to non-traditional.
Yeah, that's a great question. So those 4 papers, no. Most of them were looking at definitions and just doing, their own kind of study, if that makes sense. But I think that's part of the problem, is that we're struggling to, if we can't define community-based education, what it actually means, and we're not all on the same page about that, and we don't have certain ways to evaluate it, then we can't really compare it to traditional, because we need to be able to define both and say what's community and what's traditional. So to answer your question, there isn't very many papers, and that's part of, and this has been a recurring theme since 1985 actually, when this WHO study group met. They also said within their report that there needs to be more evaluation of community-based education and make sure it's robust, and I think we struggle to do that without being able to define it.
That's it. Right. We're going to leave that there, but thank you very much, Jenny.
Thanks.
So we're now going to take a short break. We will come back again at 2:20 for the next 3 presentations. The physical posters are available outside here, so please, I encourage everyone to go and have a look at the physical posters that are up. And I'm going to, when I find it, which I'm rapidly trying to do, I'm going to put a link in the chat here on Teams, which will take you to the online page where the posters can be viewed. There are 2 files in the online pack, one for portrait and one for landscape. So they are not grouped in any way other than that. And copy link. So there we go. So if you follow the link that I've just put into the chat, you will find a page that looks something like this. And if you scroll down, you can then view the posters, the landscape and the portrait ones, and have a look at those while we take a short break. So back here at 2:20. Thank you very much. Unmute. Hello, everyone. Right, we are back and ready and raring to go to celebrate some more success. So I will hand over.
Yeah, it says not working. I will click in here.
Some new batteries. People.
Yeah, sure. Oh, hi, good afternoon, everyone. My name is E. I'm the Junior Clinical Fellow in the NHS Fife. Today, I'm honored to represent our year-long quality improvement project called Achieving Excellence in the DNA CPR and the HACCP documentations, which were carried in the balcony wall of the Cameron Hospital together with my colleague Thierry Mason and Dr. Emma Movement and the consultant Dr. Magdalene Carter. So why this project is important, especially in the elderly.
Up, that'll be it. There we go. So now, now the clicker will work.
Thank you so much. Thank you. Why this project is important, especially in the elderly care, anticipating the risk of deterioration is very important and vital. In hospital, cardiac arrest carry a very high mortality rate. So what we would like to do is we would like to reduce the avoidable harm because prevention is better than cure in most of the cases. By using the DNA CPR discussion and the hospital anticipatory care planning, we can avoid the non-beneficial interventions like a traumatic CPR, especially in the deteriorating patient and in those who are not going to be benefit. DNA CPR reflects and guides the important division, especially in the emergency conditions. And the HACCP care planning go beyond the further. It can reflect the patient-centered care discussion and the decision and the escalation plan. Also, it helps to get the information regarding with the combined decision making between the patient and the family member and the doctor by aligning with the patient wishes and the clinical decision. So our aims were clear. It was by March 2025, 95% of appropriate patients in the Cameron Hospital balcony ward should have a DNA CPR and HACCP in place. And the objective included the timely completion and the precise documentation and empowering the MDT team awareness and most importantly, involvement of the patients and the family member in the DNA CPR and HACCP discussion. So our methodology, we use a PTSD cycle in our project. It was started in the April 2024. It evolved throughout the year to the several cycles. Initially, we focused mainly on the DNA CPR documentation and encouraging the senior clinician review and also involvement of the patients and family discussion. And then over the year, especially in the November, we started to introduce the HACCP audit together with the DNA CPR practice. The final intervention cycle were mainly emphasized in the multidisciplinary team engagement, structural handover, and the targeted intervention. We also embedded the audit checklist and the tool. It reflects the compliance of our project, and it also shows the data, not only the whether DNA CPR form is in place, but also it reflects whether the form is precise, accurate, whether the family member were involved or not, whether the escalation plan has been checked, or whether the change and the communication between the emergency and the GP crew has been discussed or not. These two, the results from the good checklist guided the targeted intervention and the re-audit plan. This is one of our visual prompts that we use in the late cycle. It was displayed widely in the MDT team room and also spread to the other ward in the Cameron Hospital and the Leiden ward and the Berkeley ward. And it added a daily reminder and the guidance for the DNA CPR and the HACCP discussion. The results were amazing. The initial audit showed the improvement in the DNA CPR documentation up to the 75%. The subsequent cycle, maintaining the DNA CPR improvement to 85%. Also, the most significant one is HACCP documentation rose significantly up to 80%. The final MDT intervention, we could able to achieve up to the 95% of our aim target. Also, the MDT awareness up to the 95% and the continued improvement in the DNA CPR HACP completion to 89%. This is the visual graphic improvement in the documentation of the compliance over the time. So our project DRI is supposed to be NHS Fife deteriorating patient framework, and it also aligns with the NHS Fife statement. All preventable cardiac arrest should be prevented, or avoidable CPR should be avoided. By observing the early warning sign, making the right pathway, we can make it enhance the better outcome, safety, more dignified outcome for a patient, especially in the deteriorating patient. And we can also save the effective use of our clinical resources. So what we learned from this project is a structured anticipatory care planning is not an optional. It is essential for the high quality care in the elderly patients. DNA CPR and HACP are not only just a documentation, they are the clinical tools that can guide the shared decision making into an action. Of course, we have some challenges to our project. This involves a step rotation and a weekend documentation gap, lot of the time to discussion with the patient and the relatives, and even to discussion with the patient for in the case of a cognitive impairment. What we would like to recommend for a future quality improvement project from this project is like this current framework is very replicated to the other work as well. The two audit checklists and the MDT and the teamwork are very replicated and adaptable. And we hope that it inspires to initiate the other work, not only in the hospital, but also to the community perspective. I would like to thank to my colleagues and the consultant and the MDT team member, nursing and the physiotherapy and occupational therapy team. So in conclusion, high quality geriatric care means planning ahead, listening well, and making decisions that honor each patient journey. Thank you for your attention, and I'm happy to take any questions.
That's right.
Yeah.
That's fantastic. And you're putting a lot of work into getting the paperwork right for each patient.
Yeah.
How many of the patients that come from here to Cameron come with that already? And did you look at how you get that information from when you discharge the patient from Cameron to the GPs? Because sometimes we do all of this work during an inpatient admission, and then we miss it getting into the KISS or whatever, so it doesn't get, we have to then redo it next time.
Yeah. Initially, Cameron Hospital backup ward is faculty ward is 25 patients, and whenever patient transferred into our ward, we collect the data, and then it is set as the initial data, and then we make the intervention on the discharge. We usually discharge the photocopy of the DNA CPR, and we also place in the discharge letter to make sure the GP are aware of the DNA CPR and HACP were discussed in the community hospital.
I'm interested in your decision making around your goals of the targets for DNA CPR and the HACP. So it's not necessarily wrong, but I'm just interested how you, especially for DNA CPR, how you decided that the goal should be a completion rate of DNA CPR as opposed to a documented decision about resus, because obviously it's going to be dependent on the individual, and most patients in our community hospitals will be frail and by definition probably shouldn't have CPR, but it's still, I suppose there's nuance there between what is a decision either way versus a decision to put in a DNA CPR. Does that make sense?
Yes, you like decision regarding whether the patient put a DNA CPR.
So your goal at the start is 95% of people should have a DNA CPR, but that doesn't take into account individuals' preferences or suitability to the CPR. So I wondered if you considered that.
Yeah, it was one of the points. Initially, our 95%, we implant the data from the IHEP of Scotland, National Education Hub Improvement of the Scotland. They are aiming to be up to 95%. I think it is achievable and doable data. And the data that we collected also included the patient who are suitable for the DNA CPR in place. Especially like we have, for example, we have 20 patients in the Campbell wards, and there was data one time 2 patients are say suitable for a CPR. So that data was also included in here. We counted as a patient does not have in a reform status, but the patient is still fit for a DNA CPR. That is our one of the need to be improvement in the future study.
I think just to pick up on James's point though, what's in personally rehab beds now isn't what's always going into it. So quite often when I get in people from vascular angles, you might be younger, better otherwise, but have an amputation, or we're getting some of these polytrauma patients into the rehab beds. Yeah. So quite often now it's not always just the person that's coming in.
Cameron Hospital, we usually got the patient transfer, elderly and the free patient. There was a few patients, just like you mentioned, the patient transfer from the 9 way. As I said before, this data also included the total data. It also included the data that are still suitable for a referral. And it is for as a patient not having a referral. And there was a lack of the population.
Okay. Okie doke. Right. And next is Dr. Hannah in the room. There we go. Great. Fantastic. There is that. And with questions, the mics don't always pick up everything in the room. So if you're asked questions, it can help you able to sort of repeat back.
Okay. Hi everyone. Sorry I couldn't come earlier. I'm technically on the call, so I've given somebody else the phone for the next 10 minutes. My name is John, I'm one of the orthopedic clinical fellows. We honestly experienced something new that we're trying in the department this year, which is giving FY1s, we don't have FY1s, not FY2s in our wards, experience days, which are days where they're programmed, they're scheduled into their rota, and the idea is to see the idea is to give them a flavour of orthopedic, something away from the ward work, where they work very hard all the time anyway, and to try and give them a nice day where they can learn a bit more, because part of the training survey is about development and learning and education. It's not just about doing loads and loads of ward work for people. So we thought we would audit that. Is this how it's going to? Oh, good. Yeah, so the aims, Scottish Training Survey, second outcomes, education and environment and teaching. That's previous questions to F1 and F2 is about, you know, how much teaching did you get with backgrounds and theoretical, all that kind of stuff. We tried to evaluate learning development opportunities, what were education-based doing, how many people get, did they find them helpful, did they just find them a bit of a pain, did they detract from work on the board, did they felt helping their colleagues, when the staff well enough, those type of things. They wanted to audit that. We're running some 2 rotations, so we sent an anonymous Google electronic survey to both cohorts and emailed them asking to fill it in. We got a reasonable response rate for people who weren't no longer in the department, so thank you very much to everyone who filled that in. For some questions, we've seen results, some questions you like a scale 1 to 5, strongly agree, and some we said yes, no, and then had written answers for the filling to feedback, anything else that wasn't covered in the survey. Hopefully this project's okay, but here's literally just the graphs taken from the Google poll. I enjoyed my experience. Everybody really enjoyed. Most people strongly agreed they enjoyed the experience days. The experience day continue. Again, everybody but one person strongly agreed they should continue to be part of the rotation. I improved my knowledge. A couple of people sort of neutral about that, but again, most people felt that it improved their knowledge of orthopedics, which is exactly what we wanted to do. Felt more senior to approach. It felt more able to approach senior colleagues. This is a really big one for us. Delighted that 12 out of 13 people thought, yes, I've worked with a team, but you know, able to put a face to a name, know that consultant, know that registrar, CDF, whoever it is. And I think that helped the sort of team dynamic, which is kind of separate part of the Scottish Training Survey. I'd like to have more experience days. Nobody disagreed that they wouldn't. And then I'd like to have less. Again, very people very strongly disagree with that. So that's quite positive on the whole. We'll do a bit more of a deeper dive into it. So experiences help me in clinical practice. Again, majority, 75% said, yeah, it's helped experience practice. If the experiences could involve going to theatre, could involve going to A&E checking on call, could involve going to the plaster room, fracture clinics, where if you're seeing the fracture and you're understanding what you do, for example, with a level B fracture and weight bear and you monitor it in a week and stuff, that means that when you're on the ward dealing with a patient like that, you know the answer. You don't have to continue to feel like you have to phone up and ask. Understanding why we've not reduced an ankle but fixed it, we left it every 48 to 72 hours just to make sure it's not coming back to being subluxed or dislocated, that type of thing. So most people did find that was that helped clinical practice. Re-energising the work, burnout's a big thing. I didn't do a big sort of audit on actual burnout in a department or anything like that, but I just thought I never got these days to an F1 or an F2, and every time I managed to do something that wasn't a regular job, coming back the next week, I just felt so much better, so much happier, so much more energized. So we sort of put that in, and again, most people will know disagree, but it didn't help them. And again, most people agree that re-energize their work can only be good. Experience days should be optional, so a bit of a mixed bag here. Feedback was some people weren't particularly interested in orthopedics, thought they were a good thing and everyone should be doing them. Some people thought that you should be able to vote, say, I am interested in surgery, orthopedics, etc., so they can maybe get some more, maybe a bit less. So it's a bit of a spread on that one as to whether or not it should be optional. And then, I mean, people said they were more likely to consider a taste a week or consider TNO training, which is another subsidiary, but that's not for everybody. So it's not surprising that we'll have people disagreeing, because you could do experience days and then go, this is not for me, which is absolutely reasonable. Having experienced this to get a little bit spread, the reason for this is partly some people swapped on the roadside, said that they were happy not to do one and to do the other. So some people think maybe nab one off their colleague. And then the other one is that people who not every F1 works the same amount, so people that work in our department and our wards more got more experience days. So there's a bit of spread, but everybody got, we filled in the survey, got at least one day, and one person roughly got 5, but most was kind of around 2 to 4 days over the 4-month block. Most people agreed that the experience days were done on days which are usually Wednesdays or Thursdays. So if you have sort of over nights and weekends and Mondays people are off, then you just say, right, come for an experience day, you might need to avoid a bit short. So we deliberately avoided that in the middle of the week. So again, people didn't really feel it left short. And one of those responses was that yes, they've written the feedback that they just had their colleague in the advanced nurse practitioner off sick. So that's just bad luck. Most people used it only for trauma and orthopedics. One person was seen in an ENT, like they had into an ENT theatre, I believe, and then somebody else used it for the Curas portfolio. So we got some who said it anything. And did they ever get cut short? It's all good and well having this in the rota and having it scheduled in, everyone know what they're meant to do. But yeah, most people got the days that they got. 2 people had cut, one by their regular weekly teaching, and one because there was sickness in another area and had to be gone. So we managed to deliver it pretty well. We're quite happy with that. Were they allocated fairly? Most people thought they were. Some people thought they weren't. That's something we will look into in terms of it's difficult because some people might get more, might get less. And if somebody's working 3 times the amount in ortho and they're mainly in gen surgery, we give them the same amount of paid experience days. So that's something we'll consider. But on the whole, people were generally positive about it. And there's the activities people did. Depending on how many days they got various things, they might spend 1 day in pizza, scrub or on-scrub, depending on what they want to do, clinics, scratch clinics, selective clinics, classroom room, on-call shadowing, that type of thing. So there's a bit of a spread of activity as well. And nobody was either aware or had in future or previous rotations these type of days, which I think is quite a unique sort of good thing to bring into the placement when we can. Conclusion, they're very highly rated in all aspects. There's room for improvements in terms of how we distribute things and the use of time. We thought that maybe make it more structured and say it's an experience day, but instead of turning up to the trial meeting and saying what we want to do, it could be dates in the morning, perhaps going to be that, whatever it is, trying to make it more sort of pinpoint. But for a sort of initial sort of programme, I think it went quite well. Most people found it helped as well, and most people found that it was done fairly. Most people got the dates that were allocated, and nobody disagreed that they should stop. So quite positive results from the polls. Have you got any questions at all? Okay.
Thanks for that. So in Fife, we've had quite a big increase in number of F1s in surgery and medicine, and another 4 in medicine and 3 in surgery coming in first. So my question to you is, should people like me be insisting that this is part of our regular programme for all F1s, not just F1s in orthopedics?
That's something to thought about, because there'll be an argument. People will say, oh, well, if orthopedics can afford to give an FY1 every couple of months a day where they're not running around the ward doing a million discharge letters, maybe they don't need this many people, that sort of thing. So, and I'm not that sort of nest supervisor allocating different people. But I do think that it's something that I did personally, wanted to do surgery, did a surgical placement and not this trust. And honestly, couldn't tell you anything about any of the surgeries that happened, because you just picked up the envelope, you just did what it did, you ran around doing all the medical things, and you didn't know any of the surgeons, you didn't know basically any of the registrars. Very sort of sad and lonely and boring. And I think this is quite a positive thing.
What about if you were at F1 in medicine, which was to do surgery?
Yeah. Oh, you mean?
Would you like to do this in medicine as well as in your F1 service?
I would have, but I would also say it's probably a wee bit different, because on the whole, I know there's medical clinics and stuff, but in medicine there's kind of wards, usually someone senior, maybe like a IMT or something like that, where you can kind of work with the person and see what they're thinking and see what they're doing. Whereas, the point that coming at 8 o'clock, do a trauma meeting, do a ward round, and we all run away to do things. So usually there's a person on call, and every second day there's usually somebody who's on a ward shift. But other than that, you may not meet any senior team. You know, so I think it does. I think it's kind of a different thing, if that makes sense. You probably have more senior exposure to medicine. I may be wrong in that, but that's my instinct. Yeah.
Thank you very much for the picking up on that point. I am interested to see how one of the feedback is that they're learning about our getting insight into what the orthopedic diploma is working for. Do you think there's role for more senior members of the team to get an experience in a different specialty? The reason I say that is because I would love to. In my appraisal role, one of the things I find rewarding in that role is that gives me insight into other specialties and what their workload is. Because surgeons going about physicians, physicians going about surgeons, but you don't really appreciate workload.
Mm-hmm.
What do you think?
Yes, but then it depends on as well. We've got people in training and not in training. So for me, I might hoping to try and go into core surgery later on. So that doing orthopedic consultation, but might do core surgery. So it would be useful maybe to have a day in gens or something like that. If you're an ST6, ST5, maybe less. So maybe you need to hone the skills kind of more in that specialty. I'm not sure. But yeah, it's something to consider in terms of like seeing orthopedic surgeon a day in geriatrics, or in where was that last Cameron House was the last stop? Yeah, and so they get an idea of what they have to deal with. It might be good, but I'm not designing a training program, so yeah. Sorry, I'll leave that up to whoever does the orthopedic training program.
Thank you. That's really interesting. It's really positive to see that the energised effect. I saw one of the trainees choose to time for an e-portfolio. Did you get other comments around that? Just the fact that people would similarly feel energised and better about their relevant time and some admin time as well?
Yeah, because something that's not built into their rota. So yeah, we did often sort of say, between cases of various things, or it comes to clinic in the morning, next day or something, like do your admin and have a nice day rather than sort of leaving running around at like got some terrorists or something happening. There's nothing super specific that I can remember. So we didn't leave a box for everyone to comment, mandatory comments on everything. It was more a couple of sort of boxes for people to fill out feedback. There was one comment that I remember that I don't know who it was that filled that in, but they said that they found it really good because when they basically been trying to do their logbook for ages and get enough cases for things, and that person went to the ENT, I think. I don't know, but I think so. And they were like, well, this really kind of helped me. I went to the ENT, on cauterized somebody in ED, which I know it's not orthopedic, but that person's being proactive, taking charge of their learning, doing something they enjoy, doing something interesting in later life. I think if we can possibly afford that for people, that's quite close to it.
Thank you very much.
Cool. Cheers.
Right, and that brings us to our final presentation of the afternoon. And Mo is here. Yes. I don't know if the pointer, you won't be able to see the pointer at home. But when there's a mouse just projecting. The other thing is, people at home don't always hear the questions from the room.
Okay. So,
okay.
Should that be done?
This sort of the cameras up there, sort of general
Good.
Pick you up.
Okay, so good afternoon, everybody. My name is Mohammed Ali. I'm a GPSP2 at the moment. I kind of did this audit when I had my EOT placement that ended in February. So I will tell you all about it. At the moment, I'm doing medicine and but yeah, thank you so much for being here. I think you've had a long day, but I'll make it very short and concise and to the point, hopefully. So our audit was basically about evaluating post-selectomy analgesic regimen at the ENT department in the Victoria and Green Market Hospital, obviously. So the aim of the study was basically to evaluate the effectiveness of post-selectomy discharges and if there's any readmissions, to examine those readmissions and find out why they presented back after surgery, and obviously implement a protocol to kind of reduce the number of readmission and the amount of complications that they're having, and finally measure the results. So we did a full 2 audit cycle, and we kind of compared the cycles and the results of those. Our methodology was really simple. I think in the first cycle, they went retrospectively and measured 4 months of readmission for post-selectomy. They looked back into their date of admissions and why they presented back. And obviously after that, they implemented a simple protocol. This protocol was compared with local NHS boards across the country and the American Academy of ENT and Head and Neck Surgery. So during the first cycle, they noted that there was 10.6% readmission with post-selectomy pain. They did not include all of their separate readmissions. We're not really sure what other causes of readmission, but we know that 13 patients out of 123 patients presented with pain after their post-selectomy. So as I said, after comparing with local protocols, they implemented a very simple but direct and very helpful protocol to be given to everybody post the surgery, which is regular paracetamol, ibuprofen, and diaphragm spray. Although it appears very simple, when we did the second cycle, which is before we did the second cycle, obviously the department had to they were in learning to the department and about this new protocol that has to be in place, and the discharge letters were double checked that everybody with after post-selectomy must have the communication in the discharge letter. And after the year of this protocol being in place, we did a second cycle where we measured again retrospectively 4 months of a period of readmissions after post-selectomy, and we then compared the first and the second cycle. And the results were, I would say, amazing. There were a total of 13 patients readmitted out of 160 total tonsillectomies in both Victoria Hospital and Queen Margaret. This time, only 4.3% versus 5 patients presented with post-tonsillectomy pain. The rest of the admissions were mainly because of bleeding, which was not obviously relevant to our audit, but we just kind of wanted to know what other complications to kind of give us a guide about future audits that we might maybe work on. So this is just a small comparison. So we noticed that huge drop in the post-tonsillectomy bleed. It goes up to 60% almost rate reduction in pain-related complications post the patient surgery, and with an absolute reduction of 6.3 from 10.6 to obviously 4.3, and with 3 direct and simple medication protocol that is now in place and being used regularly. So the conclusion of our audit is that this protocol is obviously very effective, and there's a very significant reduction of both complications to the patient and possible of its cost reduction to the service. And we kind of we highlighted the need for further auditing regarding, for example, what we need to do with the patient with comorbidity and what other complications that might result from happen after tonsillectomies and how can we deal with them. So those are ideas for our future auditing, and hopefully we might get working on them. That was just my audit. If anyone has any questions, please feel free.
Just wondering, is there not a nationalised, was there absence of nationalised protocol? Okay, get, or was Fife just not aligned to it?
There was definitely not a clear guidance, like specifically towards possibility, but we kind of found regional, like very like local based guidances about like just few departments that are doing this, but there wasn't really a national NHS guidance in the UK to say every patient post-transplant must have this list. The American Society said, Academy of ENT said they might benefit from this, but it wasn't also a must be done thing. But obviously, we've noticed from the amount of creation that let's try this. But if it obviously didn't work or it didn't do any improvement, but we might have stopped there. But I think the results were very indicative that it's very helpful.
But actually, there's game changing practice. While before all our tonsillectomies were done as inpatients in the Victoria side, looked after and discharged by FYs and GPSCs. Then we started doing tonsillectomy in Queen Margaret in day surgery, where they are discharged by nurses that have not done ENT patients before. So that's where the discrepancy between the two sites were. And that's where we decided.
Did you give any guidance about duration of analgesics that should be supplied? Because hospitals are quite strict of they want to give 7 days, but tonsillectomy from past recent experience, pain is worse than 2. So I just wondered if that was included in the guidance.
It wasn't really included in the guidance. I think when we were in the department, we were certainly giving it 7 days and giving them a strong word to advise that the pain is not really fulfilling before the end of those 7 days. Just get in touch with us or the GP, because in ENT they can easily get in touch with our phone team. We can give you more, but yeah, there wasn't really a specific like timing given, but it's usually a week supply and more in contact us or the GP.
And then that's something you can look at for different cycles. So don't think tonsillectomy pain is gone after 7 days.
Yeah, this is something definitely we can look into, but we haven't had really a lot of contact for it. Yeah.
On the point Gary's making, I wonder, did you look at the data of readmission for pain? So was it kind of what day post discharge was the readmission?
So that was documented in, we have a booklet that we included every patient that comes in with every complication, regardless of it's tonsillectomy or not tonsillectomy to the department for our governance meeting purposes. So we kind of document the day where exactly the pain starts. And we didn't really found any like significant pattern. Some patient presented after 2 weeks, some patient obviously the second or third day, but we couldn't really find any specific pattern to say the maximum day of presentation is, let's say, day 7 or 5%. But yeah, this data is available for our other purposes. Is that all? That's fine.
Thank you. Right, and that brings us to the end of our presentation. So we're now going to take 5 minutes to put our heads together as judges, and so please do hang around. I'm just seeing what we've missed on chat. I think that. So yes, give us 5 minutes to confer. We will be back with prizes galore. Right.
What's glory for me, man? My glory was spending 65 minutes to stop a bleeding. Yeah. That was my glory. I haven't got this. Oh, yeah. One of which. 69. Yeah. But I just. Leave it, and then when you come back, it's straight back. Yeah. It's like it's just it's big gadget in a net. It's big enough that it doesn't look like. So that's being right. That's not right there.
I think it's.
Usually shouldn't. I think here I don't see it in this weekend. I'm just going to yeah, it's it's not very bad. There's a summer. It's absolutely yeah, you know, ALS training. Training. ILS today and IMT trainees. Is that IMT training today as well?
There is, but it's guidance to the logbook for which the deadline was on Monday. So I'm not gonna lie.
No. I'm just saying if we should choose a date for this group because there's lots of F51 education happening. There's IMT training today, and we've done this. So probably you'll have less choosing a day. Why prize giving ceremony? I just do coffee.
Right, are we unmuted? Yes, we are. So that was absolutely fantastic. Thank you to everyone who's come along, everyone who's presented, everyone who's submitted work. and the posters. And I do encourage you, we're not going to be taking the posters down online. So do have a look at that. If you haven't had a chance to look at the link and have a look through some of the posters that have been submitted, because there's some fantastic work there as well. And already start thinking about what you can present for next year. If you didn't present today, get something ready for next year and get it presented. So I'm now going to hand over to Dr. Baker and Dr. Woods, who are going to tell us who has won.
Exciting. Thanks very much, Ollie. I'm here both as a local physician and therefore really impressed with the quality of local work that's going on, but also as the Dean of Education and Training at the Royal College of Physicians of Edinburgh. And we love sponsoring this event because it's so great to see what's happening locally. And as you've already seen from slides, I think that district generals such as this often outperform some really big tertiary centres in terms of that enthusiasm, but also kind of pragmatic approach to finding solutions. So it's been really lovely to see that work continues. And it's been fantastic to see just the broad range of quality improvement work that's been happening through the posters and through the oral presentations. So on behalf of the college, thank you. We're really thrilled to be part of this. But you're not here to see me, you're here to see who has won the presentations. So I will be covering the oral presentations, which were fantastic, really great range, really high quality. But judges were unanimous in who we thought should take home first prize. So I would like to call up Dr. Chandler to say congratulations to you and Paddington there. Great to see. We love to see things like the quality improvement cycle of college. All we do, see the results, thinking about what we can adapt and change next time. It wasn't just because you said we were better. So thank you ever so much for that. Well done again. And I'll pass across to Dr. Woods.
Oh yeah. Okay. So I was judging the poster presentations with some input from some colleagues as well. So it's always great to see the range of different topics covered, from case reports to audits and quality improvement projects. And the winner this year is Improving Therapeutic Efficacy of Vancomycin in Neonates, a QI project, which is Yana Hassami and C. McFarlane and A. Yasmin. I don't know if anyone's here, but well done. So they will also get recognised as if not in the room. But yeah, thank you very much and well done to everyone. It was difficult to judge it, but yeah, some really high quality improvement work on display. So thank you very much, everyone.
Yes. And so that brings us to the end of the afternoon. Thank you again to everyone who's come, everyone who's presented. Congratulations to all of our winners who will be getting a year's subscription to the college of their choice as their prize. It can be your own. You could decide to join a different college for a year in order to make the most of that. But yeah, so fantastic. Thank you ever so much, everyone. And goodbye.
And thank you so much.
Oh yes, and thank you to the Chief Registrar for right, thank you.